So we are going to move right on to our next talk here, our panel discussion, Overcoming Barriers to Neurosurgical Training in Africa. So on this panel, I'm going to have Dr. Ogutha, who's joining us from Kisumu, Kenya, Dr. Olunya, who's in Nairobi, Kenya, and also Dr. Roger Hartle. Is Dr. Hartle, has Dr. Hartle joined us yet? No? Okay. We'll go ahead and get started. The first, really, to understand how to advance educational training in Africa, I think we have to first, understand the history of neurosurgical training in Kenya. So, Dr. Olunya, I know you're very familiar with the history of neurosurgery in Kenya and the history of neurosurgical training in Kenya. Could you give us just a quick rundown on how neurosurgery training started in Kenya and where we are right now?
Thank you very much for that. Initially we had our training schemes which were carried out outside the country, and in about 2006 there was an initiative from not the people in Kenya but from the St. Louis group to try and get us together to get a training scheme done. We were able to get a program, and this program was able to put forward actually two training programs that have been going on in Kenya. And this similar program went out in East, Central, and Southern Africa region. So it's an MEd program which is offered at the University of Nairobi and the surrounding countries, and also the College of Surgeons Eastern, Central, and Southern Africa training program. The MEd program is a university program where you have to have a thesis, and Leo Ogutha is one of those who have benefited from that. But the COSEXA program is that which is trained surgeons have a collegiate method of training, rotations, no thesis is done, but they have a series of logs and papers produced, and at the end of it have an end exam. Why I'm mentioning these two programs is because this is what has really fed us with getting training carried out. The advantages of this, like I said, when we had initially one neurosurgeon and two, then we have, I think at the last count, Lee, if I'm correct, I think we're about 40 in Kenya, just about 40. And there are some who have benefited from the MEd program, the COSEXA program, who are around the region. So that is basically where we are now. And it's encouraging to note that in Eldoret, on the count, I don't know how many there are in Eldoret, and in Kenyatta as well, which is in Nairobi. That's where the two biggest centers where most of the neurosurgeons are. But within the country, there are people who are practicing neurological surgery. I think maybe, Lee, you have what more to add on our numbers and how we're doing.
Yes, just to add on a little bit, we are 39 practicing at the moment, and Eldoret actually has 6 neurosurgeons. And then the training program, the MEd program, has quite a number of residents. I think about 40 residents at different stages in training. So we are hoping that the numbers can grow in the next few years.
That's pretty remarkable, considering we're looking at 39, 40 neurosurgeons in a population of 50 million people. So it's one neurosurgeon to 1.2 million or so. So that is really remarkable that you're able to provide these services. But I would imagine how overwhelming it is for each of these neurosurgeons, because for example, here in Columbus, Ohio, our population now, what would you say, Dr. Karras? Probably, if we count the entire metro area and surrounding area, maybe we're looking at a population of 2 million or so, maybe 3 million. And with that, just in Columbus, there's probably 50 neurosurgeons. So it's at least 40-something neurosurgeons just in Columbus alone. So it's amazing, kind of the numbers, the difference, the disparity in the numbers. I think that World Health Organization recommends typically about one neurosurgeon for every 100,000. So it's amazing.
Do you mind if I ask, can somebody, maybe Lee, give us the rundown of the current state of education for neurosurgery residents? How many years does it take, and how does it proceed from, say, high school forward? Once you've graduated high school, what type of medical program are you in? If you can just give us a 1-minute rundown of how they become eventually an attending neurosurgeon.
Sure. I can comment on the MED program, which Dr. Olunya had mentioned earlier. So typically, after you graduate from high school, you go to medical school to get your bachelor's degree and to become essentially a general practitioner. And so for most programs, they are 5 or 6 year programs, after which you do a year of internship, you work under supervision, and then you become a licensed medical practitioner. So at that point, you're a general practitioner. And for most Kenyan doctors, they'll work for a couple of years before they pursue training either in a master's program or in a fellowship program like Dr. Lunya mentioned. And typically, the program I attended at the University of Nairobi was a master's in medicine and neurosurgery. And that is a change from before, where everyone had to train as a general surgeon first and then subspecialize. And so now you can enter directly into a neurosurgical or urology or plastic surgery or orthopedics program. And so the neurosurgical program at the University of Nairobi is a 6-year program. And the first year, you essentially domesticated in anatomy and physiology, and you do dissections and go through neuroanatomy and neurophysiology. And the second year, we rotate through general surgery, orthopedics, pediatric surgery, and critical care. And then in the third year, we add on rotations in neurology, neuropathology, ENT, ophthalmology, and then we proceed to the clinical years where you're fully domesticated in a neurosurgical unit. So in your 4th year, you start to do more neurotrauma. You take calls, you are attending surgeries in the trauma theater, and also assisting in elective procedures, and that continues for the next 3 years. So at the end of the 6-year program, you have to have a thesis, a research project done, and you graduate, but you have a year of pre-registration, which means, again, you're not registered as a neurosurgeon, but you work under supervision of a practicing qualified surgeon for a year, and then you can get your registration and we move from there.
Thank you. I have Dr. Roger Hartle. He has joined us, so I'd like to introduce Dr. Hartle. Dr. Hartle, thank you for being part of the faculty for this symposium. He's a professor of neurological surgery at Weill Cornell in New York, and an inventor and a leader in global health, as well as he has many publications. I would like to welcome Dr. Hartle. Dr. Hartle is going to be part of this panel discussion on barriers to neurosurgical training in Africa. Dr. Hartle, real quick, I know you've been involved significantly in Tanzania. What have been the barriers to training there, and kind of what progress have you made with the Cornell team in Tanzania as far as advancing neurosurgery in that part of East Africa?
Thank you. Can you hear me okay?
Yes.
Yeah. First of all, thank you so much for having me as part of the panel discussion, and thanks for the kind introduction. I've been involved with global health and global neurosurgery, more specifically in Tanzania, for almost 15 years. And the barriers, in my opinion, from my perspective, the barriers were clearly that for us, obviously, there's a very limited amount of time that we can really dedicate to the actual process of traveling and spending time there. That makes it very difficult to really then maximize the efficiency and the effectiveness of what we're trying to do and accomplish over there. I think that's the number one main priority. Challenge. The other challenge is to really understand what are the over there, because it is hard for us to really to exactly understand and grasp what they're looking for over there and what we can do to really help them. That means that you have to have a very close relationship and very very good communication channel to really understand that. And that once you overcome those two barriers, I think that's the first step. And then you can try to build on that something that has meaning, that has substance over time. I'm sorry for the background noise.
Not at all. It sounds like, just like in any clinical setting, having some continuity is important, not just for patient care, but also for education. And so small bursts of education are useful, but they can't be the only way somebody learns over a matter of, say, 6 years in their residency program. How difficult has it been to keep the people who are being trained in neurosurgery in those areas, in Tanzania, in Kenya, to then teach the next generation? Of the 39 attendings now practicing in Kenya, for instance, how many are participating in education? And do you find that getting them on board to educate is a barrier, or have they been open to educating the next set of residents? Lee,
I think if I may add here, our training is an apprenticeship, and if you do not get someone to show you the ropes, you can't do it theoretically. And I think the onus is on us as the ones who are more experienced, or have had more problems in our practice, to be able to offer this to the younger generation. And just that camaraderie in terms of letting them see and do and work with you in terms of the training is extremely useful. In Nairobi and also in Eldoret, they are both attached to universities. And within the COSEXA training program, there's always an attending who has gone through that system of training. So in terms of that continuity, I think that goes in part and parcel. It's very rare to get someone who has been through that training to be selfish and not hand that information across. That's number one. Number two, in terms of continuity, the burst that we get in, like for this symposium, the barriers have been reduced because of internet and how things have had to work. We all have collaborative centers. Fortunately, now we're talking about you in the US. Now we've got our friend across from Kuala Lumpur letting us know about that. We have got strong ties in India, got strong ties in Britain, some strong ties in South Africa, and all around the continent. And what we have done in collaborative approaches, our senior attendings have seminars like this, and our residents are actually invited to be able to go. So on the COSEXA program, we've had people going across through to India, to Turkey, to Britain, and I know across the US, Halif Abdi Fattah was supposed to have come across, but he didn't make it because of COVID. I hope he's still going to come across. But all of these things help our residents not only see what our local experience is, if we don't have the expertise coming out to Kenya, but they can also have a chance to visit and see what happens elsewhere. Thank you.
If a resident wants to apply to, if someone wants to apply to neurosurgery residency, what is the process for them? How do they apply to the residency, and how do you select your residents?
I think Lee had mentioned about how after they finish their A levels, or they finish the university training, there's actually an application, and when they do the application, they have to sit an examination, and with that examination, then there's an interview, and after that interview is carried out, the ones who are selected are brought in for the MEd program. For the COSEXA program, there is application similar to that. They have CV circulated, and in the different training sites, the slots that come through are very few. So I think per country is only about 1 or 2 per year, and they are put in different centers, and you're hoping to get more. And with that, there's a selection process for the residents to come through. So at the end of it, if you look at the caliber of people who are entering both of these programs, they are ones where, for us as people who are attending, we are happy enough to suggest that, of course, the risk that we are putting ourselves are saying that we would want these residents eventually to look after us. So if they cannot be good enough to start training, then we shouldn't be able to allow them to to enter the training program. Lee, you've got something else to add?
Just a quick question. How are they funded? In the States, we have a system where our residents are salaried through our government dollars. If a resident gets selected either into the university program or COSEXA, how are they maintained during the course of their training?
In the COSEXA program, at least the residents from the ones in the Nairobi in the Kenyan program, we have a stipend from the World Federation of Neurological Societies, and with that, it gives them a basic living wage from that. We do not encourage them to do what you talk about, fly by night or extra locums to get funding. But that is where the funding comes in. But I think from the University of Nairobi, what's the question, Lee? Can't hear you. Put your...
Okay, so I was saying at the University of Nairobi, a good number of the residents come in after being seconded by their county. So Kenya has a system where we have 47 counties, and a county can second a resident, or a hospital can second a resident for training, in which case they continue with their salary until the end of the training period, after which they are bonded to return to their county of origin and serve at that hospital that has supported their training. A few trainees have been self-sponsored, where the trainee is responsible for meeting fee obligations, and that usually comes in as an individual arrangement for that particular trainee. But the majority either come with support from their county of origin. There are also a few international students who have been trained in Nairobi, and some of those come seconded by their home governments.
Can I say something real quick? In terms of the barriers, for us, it was a huge change then, an improvement once we started collaborating with the university hospital in Tanzania, which is obviously closely integrated with COSEXA. And then to have an organization such as COSEXA involved, is really the key to success. And then the question for individuals like myself who come from overseas, from Europe, from North America, from other parts of the world, and who want to try to help and try to establish a successful program, I think it is key to partner up with an infrastructure that's already there. And for us, certainly, the University Hospital in Dar es Salaam and then COSEXA, that has been an absolute blessing, we were working at a hospital further north in Tanzania that didn't have those associations, and that was very, very difficult. The needs were there, but it was just not realistic to expect the continuity of care then, and the ability to really then pass on the knowledge, which is what you were asking for before. So I think you have to partner up. The right organizations have to partner up.
There are questions from our participants, some follow-ups about the funding of neurosurgery residents, and it sounds like there are many avenues for funding. Does the funding limitation then limit subspecialty education? Are there many or any of the residents seeking fellowships afterwards? And if so, are they available in Kenya or in the region? Or are they going to Europe and other places for their for any subspecialty fellowship training, including, say, pediatric neurosurgery?
Thus far, our, what we'd call subspecialty or super specialty hasn't been that developed locally. One of the fewer ones which are starting off is endovascular neurosurgery. We don't have a program as such. In terms of pediatric neurosurgery, the areas where we do more pediatrics. In terms of neuroendoscopy, there are areas where people do more of that, but something that is set as a fellowship per se locally, we do not have. So we rely heavily on our partners abroad to be able to assist. And I think what has been useful, since both these programs are recognized, and you know the level of how our residents are when they come up, when they go for their fellowship programs, for fellowships, they are able to benefit maximally from whatever it is that they're trained in. So currently, our endovascular specialties, we've been partnering with people down in South Africa. We are in terms of when it comes to neuro-oncology or radiation specialty, that is being developed, and we're having some of our partners in India to be able to take our residents who are finished, and in post fellowship, we've got people who have gone across to Britain and have looked at endocrine specialty as well. So I think we rely heavily on our external collaborators to be able to get to that next level. Thanks.
Very good.
Maybe what I'd say in addition, perhaps, is that for the graduates of our programs, particularly with the MEd program, we are almost always aware that we would need to follow up with a fellowship just to improve the exposure to the surgical disciplines that cannot be available or commonly done here. And so usually after a couple of years, most of my colleagues will pursue a fellowship. Popular destinations have been Canada, India, and the UK. And so at any point in time, there's usually one or two of us who's out pursuing a fellowship. And it's a really important step, I think, in our training and bridging that gap of expertise.
Very good. This panel is broken up into two parts. There are those on the ground in Kenya and in the region always, continuously, and then we have Dr. Hartle and Dr. Awar who make trips and try to support the education programs. What, from your perspective, Dr. Gutha and Dr. Lunya, what do you think those who come intermittently can do most to help specifically the educational portion of the programs? Not so much the clinical side, bringing, equipment and labor, but on the education side, what is it that those intermittent bursts of assistance can do to most help the education programs?
I think prior to COVID, I think Victor probably saw how many residents would be on around with us, both from the COSEXA program and on the MEd program, who are taking part in the physical aspect of things. The seminars that we have, like the one that we're having today, I think it's important that the residents are able to therefore patch in. And I see on Ohio Health, you have your CME range of movements that are going on in terms of your discussions. If they can be patched in, and vice versa, at the University of Nairobi, the MEd program, they have regular CMEs, and I think once a week they've got neuropathology, once a week they've got neuroradiology, and the cases that I discussed are very, very enlightening. So in the same way that things are collaborated for, we should patch it both ways. So when you're having your CMEs, I know the time differences are a bit awkward, but I think once a fortnight or so, those two can be patched together. And as far as the COSEXA program is concerned, at the Nairobi Hospital, we do a pathology discussion every week. It's a wide range of pathologies that we discuss, but not necessarily neuropathology. And that's a fixed program on Thursday morning. And these are the kind of ways that, as you've asked, we can patch in. Because we've got internet and because we've got this room for discussion, this can be used for. So with Vic and your group for the Consumer Neuroscience Initiative, this should be and must be opened up. So what we will do, therefore, is to encourage our local, COSEXA isn't there at Kisumu yet, but of course Lee is now a lecturer at Maseno University, so you can see how you can patch those people across. Over to you, Lee.
Thank you, Dr. Lunya.
Also, I see Roger's got his hand up. He's got an amazing program that he's developed with the Tanzanian neurosurgeons, where they regularly do conferences like this, and I think it's an important way to maintain the continuity. So I see a hand up, Roger. I know that's something that you really take a lot of pride in, and I'd like you to talk to us about it, because I think it's a model that we can work with.
Yeah, thank you, Robert. I just wanted to say a few words because they mentioned earlier, they were traveling, but the point here, from my perspective, is thinking about how can you make this work long term. That you're thousands of miles away, but you can still contribute to education and training. Just relying on traveling, going once or twice or even 3 times a year is just not sustainable. So what we've done is I think we developed a very successful and very sustainable model where you can create a relationship with a hospital system across on the other side of the world that does not rely on us constantly traveling over there. You need a little bit of funding for that, and we have done that through donations from patients who are generally very, very generous over here, and sometimes also industry. So we have Zoom calls every week with our partners in Tanzania where we discuss ongoing projects that we're working on. We have a research collaboration where we collect data in Tanzania, and the reason I do that is not necessarily because of the research. It's really just to foster a relationship and give the colleagues over there an opportunity to get involved academically, which I think is very, very important. And then we have fellowships. We have fellows that go back and forth. So we have Tanzanians who come to New York for a limited time period, and then we have fellows from North America, from Europe, and from other parts who actually spend 1 full year in Tanzania working. And for that, you need a little bit of funding. And then we write papers. We publish publications together. So we've gone away from sending equipment, for example. I don't find that very sustainable or successful because then once you send things over there, you're responsible for that equipment, and that's a problem. But it's our model is really heavily based on Zoom calls, on fellows going back and forth. Yes, we travel once a year, of course, but then during COVID, we didn't travel for 2 years, and it was still a successful program. So you have to have a back and forth, a sustainable model, and traveling alone is not going to do it, and sending equipment alone is not sustainable either. So it has to be focused on training, on education, and I think also research, because research gives you an opportunity to communicate. And that's the key. The communication is key. So the research is just a tool for communication. But the benefit then for them is that they get involved internationally. They write papers. They have that platform to kind of make a name for themselves. So those are kind of like the key components of what I think is a sustainable model.
Just one more question here for Dr. Ogutha. One of the challenges, I think, especially with putting this particular symposium together, was getting our colleagues in Kenya to sign up and register for the conference. What can we do from our end, or what do you think the barriers are to making that process easier so that more people will register and actually get involved when you do host these kinds of conferences?
Well, one thing, maybe just a quick comment on the previous question about how the intermittent visits can make a difference in education. I think it's perhaps something intangible, but it's about inspiring people in the sense that we see a different standard of care, a different way of practicing, but not just for the surgeons. Dr. Raora, for example, came with a couple of nurses, his theater tech and physiotherapists, and I've tried to rope in our nursing staff and our theater staff and our physiotherapy team to kind of tag along and see how things are done. So the skills transfer and the training is very valuable, even when it's intermittent, in the sense that it kind of gives an extra kick of motivation and an inspiration to kind of aspire to do things in a different way. In terms of participation for this particular conference, actually one of the challenges has been, and I've been getting reports about this throughout the day, is that people have had some trouble registering. They're trying to register and they're not getting through for some reason. So I've just sent the other link that I think you posted on there as well to see. In general, there's a lot of interest in the seminars, and I think the COVID period really got people to see how they can benefit from kind of online virtual interactions. So in this particular case, I think it's just been more of a challenge of people registering directly for the seminar or the symposium. But in general, there's pretty good uptake when people know in advance that it's coming up. they're usually very interested in attending, and the benefits Dr. Lunya has already mentioned are considerable.
All right.
Question?
Go ahead.
Thank you. I was curious, obviously, from my perspective, a little bit of a shifted focus on pediatrics specifically, and I know that a lot of countries, there are adult neurosurgeons that have some training in pediatrics that do some of the pediatric procedures. I was curious on if our doctors from Kenya could comment on that, and if there are specific folks that are trained in pediatric neurosurgery to be pediatric subspecialists in your hospitals, or if there are pediatric specific hospitals where these folks are training. I'll finish. I want to know the answer to your question, but I'll just add something else. Kind of related to what Dr. Harlow was commenting on, which is that we started an international fellowship here at Cincinnati Children's a number of years ago. We've trained folks from Europe, Africa, and well, what I'll say is that it's a funded fellowship. It's endowed, and we got the hospital to pay for benefits for when folks come. It's a 12-month clinical fellowship. So if there would be some interest from anybody listening to this, or in your institutions or residents that potentially want to subspecialize in pediatric neurosurgery, we can certainly try to help with that. But I'd be curious to know what the infrastructure looks like currently there.
Okay,
Yes,
go ahead.
Go ahead. You first.
Yes. So when I was at the University of Nairobi, we actually would do our pediatric surgery rotation at a hospital called Kijabe, which is about an hour maybe from Nairobi. Now, the pediatrics program there was set up by Professor Albright some years ago, and actually it was a very well run and very well equipped program, a very wide exposure to pathologies, and we would typically rotate there in turns to train under Professor Albright. He left the country some years ago, and since then it's been hard to get news about how the program has started. It had kind of closed down for a while, and I think it's opened and closed down a couple of times just because it's been hard to get somebody permanently stationed there. There was a doctor called Okechi who trained with Professor Albright for many years, but he's originally from Uganda, and now he is back in Uganda. I think he's with a Q Hospital, which is a pediatric dedicated, or pediatric neurosurgery dedicated hospital in Uganda. And so I cannot say that I know of a dedicated center for pediatric neurosurgery at the moment. A couple of colleagues, there's one I know who was training in Canada in pediatric neurosurgery. But currently, I don't think we have somebody specifically subspecialized as a pediatric neurosurgeon.
Okay, well, we're going to have to move on. So let's stop there, and if we have any time at the end, we can continue the discussion. So we're going to move on to the next talk.